discussion here, and we start with the first speaker, who is Dr. Soham BASAK, and Dr. Soham is going to talk to us about tips to achieve big bubble in deep anterior lamellar keratoplasty. Soham, over to you.
Thank you so much, sir. Let me get my slides up. Is it visible, sir?
Yeah. Absolutely, Soham. It's visible and you're audible.
Right. A very good evening, everyone. And thank you at the outset. Thank you, Chitra Madam and ARC, for giving me a chance to talk on this forum. So I'll be talking about tips to achieving big bubble in DALK surgery. I have no financial interest in this talk. And in fact, we are actually celebrating 20 years since Anwar described it way back in 2002. What he says about achieving big bubble DALK, you do a partial thickness corneal trephination, then you insert a disposable needle with a bevel down and then inject air. What it then does is it separates the descent membrane from the overlying stroma. Then that is opened up and the stromal layers are removed. And then finally, we move ahead with the DALK procedure. So this is what he described in 2002. 2 decades later, the steps are pretty much the same, although with some refinements and modifications. So then the natural question arises, why bear the DM? Certain publications say that it gives the best visual outcomes. And there are contrary publications where it says that with suitable amount of manual dissection where you're going quite deep into the posterior stroma, the visual outcome is actually not different. And more importantly, we all surgeons feel that it gives a lot of excitement during surgery. So that's why you should always bear the DM whenever possible. Mechanism, the entire idea of doing a big bubble DALK is taking advantage of how the corneal stromal layers and collagen fibers are arranged. So difference between the anterior and posterior, central versus peripheral, and the presence taking advantage of the predesmatics layer. So these are the 2 types of bubbles that we encounter commonly. The one on your left is the type 1 bubble. It forms between the posterior stroma, and the blue, that is the predesmatic layer. The type 2 bubble forms between the predesmatic layer and the descent membrane. Usually the type 1 bubble is slightly smaller, maybe 8 to 8.5 millimeters, less chance of perforation since you have got 2 layers here. It has got whitish margins and it forms from central to periphery. Type 2, if you're encountering, it's got a very high chance of perforation. It extends almost all the way to the limbus. It has got very clear margins and it starts from periphery and then expands. The ideal cases to do a big bubble DALK is basically keratoconus, except post-hydrops. Then you can also do it in lattice or granular dystrophies. Less ideal would be macular dystrophies, deep stromal scars, and post-RK patients. Not ideal are the full thickness scars, previous history of perforation, or previous hydrops. Now, reaching the depth. What Anwar described is you go take out part of the stroma and go deep inside. So initially, to reach the depth, we do a partial trephination. So it can be done using guarded trephines, diamond blades. Now we have the femtosecond laser and also the intraoperative OCT. Or you can simply use the normal handheld trephines and go maybe 50 to 60% based on your surgical experience. Preoperatively, 2 investigations are most important. One is doing the pachymetry map, either a Scheimpflug or an anterior segment OCT. Second is getting an anterior segment OCT to ensure the DM integrity. If you have access to intraop pachymetry, well and good. Now, forming the bubble, I use a bent 26 gauge normal needle to do it. There are specialized cannulas, like you have the TANS cannula, the Fogler cannula, which is a blunt with a opening at the undersurface. Then there's the Sarnicola, etc. Then you have this instrument to make a track for the needle and cannula. You need a 15-number blade or a side port to open the bubble. Corneal scissors, there are certain specialized scissors for cutting DALK, which sort of prevents injury to the underlying descents. And you have these TANS marginal dissector and the Fogler stromal dissector to easily sort of dissect the stroma. And now in this day and age, we have technology guided big bubble DALK. So either the femtosecond guided ones or the intraoperative guided OCT ones. There are publications in place which talk about how it is superior than doing it manually. Now the predictors, apart from the etiology, older age, And more advanced cases of keratoconus is more likely to achieve a type 2. Type 2 again in places of deep stromal scar. Then females have a lower probability of achieving big bubble, and larger trephination size was associated with an increased probability of getting a big bubble DALK. And intraoperative factors between central and peripheral air injection, there is no difference. Depth of the needle, usually 75 to 80% is good enough, where you are going 100 to 120 micron from the endothelium. Ideal IOP, too high intraoperative pressure, the bubble won't expand. And you can use a small double bubble for guiding your surgery. So these are the steps I'll be going over in the videos. So this is highly sped up. So first we are doing a anterior stromectomy. I'm doing sort of like a peripheral groove, and then the central part, just splitting it up using the crescent blade. So once this has been achieved, this is how you're left with. Then go deepen along the edges. So you have around maybe 75-80% depth. This is the 27 gauge needle bent at an angle. Slowly go in intrastromally. I prefer injecting the bubble from the paracentral area, so that even if a perforation happens, it is maybe away from the central axis. And inject, and there you have a big bubble. Then you do a paracentesis, decompress the anterior chamber, followed by opening up of the big bubble, and then de-roofing it. In between, you can use a sort of iris spatula or any of the blunt dissectors to ensure that the stroma is completely separated. Otherwise, you can injure it while cutting it up with the scissors. This is just angular vanners that I'm using. I do not use any specialized instruments, and these are your regular Westcott scissors for sort of opening up each of these petals. And at the end of it, you have bare descemet membrane, and you can proceed with doing the suturing. Now, if you have not achieved a bubble big enough, like in this case, the initial bubble is, after this, it is not expanding. So what you can do is take a side port blade and decompress. So you're lowering the intraocular pressure. And then when you inject, this will allow the descemets to move backwards. So go in with a side port and make sure that you're releasing a lot of aqueous. So now, and then continue with the air injection. So here you can see that the bubble, slowly it expands than what it previously was. This is the brave slash opening. So you can use either a number 11 or a side port blade. That's how it is. And if you're lucky, the descemets comes back slowly. Sometimes this does not happen. So you have to be very careful and move your blade away as quickly as possible. You can also aid it by putting viscoelastic on top. That sort of improves the visualization and also prevents a very rapid deflation of the bubble. And once that it has been opened, then you go in with a visco cannula and inflate it with viscoelastics before opening it up. So here you can see against the glow of the iris, you can make out where the brave slash has opened the posterior stroma. And what you're seeing underneath is the bare descements membrane. Now coming to the concept of marginal dissection, sometimes the bubble might not form all the way in your trephined edges. So what you can do is, so here I'm trying to deflate and again sort of expand the bubble, but still this part, the superior part from 12 to 2 o'clock is, so at the end you just use a blunt dissector to separate the stromal fibers before cutting it open. Now complications. So first is, if you have not gone deep enough, you will not achieve a big bubble. So what you can do is you can try deeper and at a different site. So here I just getting some stromal emphysema. So I move in deeper and at a separate site. And you can try again to get it. So if you're not getting it still, then you can use a air viscobubble technique as described by Dr. Sarnikola, or convert to any of the manual dissection techniques. So then you can have mixed bubble or a type 2 bubble. So this is a case of macular dystrophy. Nice bubble initially. But when I am finally removing it, all the petals, you can see that there is a type 2 bubble formed underneath. Fortunately, that did not rupture, and this air in the interface will slowly go away with time. The second one is a case of keratoconus. And initially, here you can see this is a type 1 bubble which is forming. So before I realize it, it has already gone quite peripherally. So if you get a type 2 bubble, better to convert to a manual dissection technique. You can still attempt, but usually there is a very high chance of perforation. And this is exactly what happened in that case. So this is the same case. While removing the petals, unfortunately, I ended up with a perforation. And that DM just rips quite a lot. So very difficult to rescue. I had to convert to PK. This one again is a macular corneal dystrophy. So going in, so this one actually formed mixed bubble and then it ruptures into the anterior chamber. So bubble, and then now that you're seeing suddenly, that is actually bubbles which has gone in the anterior chamber. So again, this is something which you will have to convert to manual dissection. So finally, for successful big bubble DALK experience, choose the correct cases, have the ideal instruments, follow and master a single technique, ideally initially, and later you can learn the other techniques for as a backup. Judicious use of technology if available, and of course you should know when to convert to manual dissection, because always doing a DALK is better than doing a penetrating keratoplasty. Thank you very much.
Thank you. On to you, Dr. Himanshu.
Very nice, Soham, and you made it so easy and so beautiful. Very nice. So I would bring in Dr. BASAK here. This is very rare, where you can have father and son both on virtual dais, and it's heartwarming to welcome both of you. So, Dr. BASAK, I remember you had presented in I think a few years back in Reshmi Award, those small bubbles which you expand, which you go deeper. Can you elaborate a little bit more? You're muted, Dr. BASAK. You're muted. You're muted, Dr. BASAK.
You have to unmute yourself.
Maximally done by my colleagues. So the concept was that if you identify the small bubble which is nearer to the DM, so you can use that small bubble. So intraoperatively, we put a pad up because we did not have any IOCT that time. Even now, we didn't have any IOCT. So you send the patient to ASOCT and take several scans. So you will find which bubble is more nearer to the DM and try to expand that bubble. So that was the concept done by my colleague and myself, and he was successful and he presented this in American Academy. That was a micro bubble expanded more to a big bubble. Here, Mustard is there. Rajesh is there, and
I'm going to come to him.
I mean, I am a big fan of Rajesh about.
I'm saving him for the last. Don't worry, I'm coming to him. So before that, I want Sunita to come in. Sunita, so many times it does happen in especially beginners' hands, or in fact, it has occurred in my hand many times, where you get such a big emphysema that you really don't know whether you have achieved a bubble or not. So how many times we should try, or we can try after debulking that? Or do you think the emphysema is too big, then it's better to convert to the manual dissection? How do we solve that?
I think the emphysema is usually we get only when we are very superficial, your needle or whatever your cannula is superficial. So I think it's initially when you're injecting, it is good to just look at how the air bubble dynamics are going in the corneal plane. So if you see that it is going more towards the periphery and you're getting more of an emphysema, initial part I generally like to be a little bit slow because I want to see how the bubble is spreading out. So if it is going towards the periphery, I'll stop there because I know that I'm a little superficial. I need to go a little deeper. So going in the periphery is one sign that you are not in the right plane. You need to be a little deeper than where you are.
Okay, that's a good point. Dr. Rajesh Fogla, I think we all have been a fan of you, and in fact, we all have learned from you this thing. So I've seen that many small things which you do, which has a reason, which many times we don't even understand. One such thing was you not decompressing the anterior chamber before. Can you tell us why do you do that, and what's the logic behind that?
Well, the thing is, experimental studies have shown that the size of the bubble has an inverse relationship to the intraocular pressure. That means if the pressure in the anterior chamber is higher, you will get a smaller size of type 1 bubble. And also, if you decompress the chamber before injecting air, the counter pressure is reduced, which means that when you get the type 1 bubble, you lose control over how the bubble is expanding. And sometimes if you're using a 5 cc syringe with 3 cc of air, you may inject too much of air or the air is compressed in the syringe. So by the time you see the bubble forming and you decide to stop, the bubble can reach its maximal size and have a spontaneous rupture as well. So it needs a great deal of control when you decompress the chamber and you inject air. So by not decompressing, the advantage is that the aqueous acts as a counter pressure, so which prevents the bubble from enlarging too much. And also a type 2 bubble, if it forms, you don't know which area it's going to form, and it can go all the way to the periphery. If you have done a paracentesis before, you've already created a break in the DM. And if your type 2 bubble expands and it reaches the point of the paracentesis, then what will happen is the type 2 bubble will just rip open at that point of time.
Thank you. So nice.